Assalamu alaikum everyone. I'm Dr. Aman, a resident neurosurgeon at Punjab Institute of Neurosciences, Lahore. Today I'm presenting my topic on outcome in cerebellopontine angle tumor surgery using electrical physiological monitoring for the preservation of the facial nerve. So why facial nerve monitoring is important? Intra-operative facial nerve monitoring aids in localizing the nerve displaced by the tumor, detect nerve injury during dissection, provide means of assessing nerve functions after dissection is completed. Since Paris in 1986 introduced the direct electrical stimulation and loudspeaker monitoring, it has been the gold standard for intraoperative facial nerve monitoring in CP angle surgeries. So the location of the tumor is important. It's usually adherent to the facial and vestibulocochlear nerve. The CP angle tumors involving the facial nerves are usually schwannomas and meningiomas. And the three approaches regarding related to the CP angle surgeries. Well, the most important thing is the surgical complications. Hearing loss and facial paresis is the most main complications related to these surgeries. Well, this is the descriptive study which was conducted in the Department of Neurosurgery Unit 2 for the period of 3 months from November 2020 to January 2021. Currently, no regional data has been recorded regarding the intraoperative facial nerve monitoring. We take a sample size of 10 cases, and House and Breckman grading of the facial nerve was recorded, and retrosegmoid surgical approach was the main approach for the tumor section. We exclude the extremes of ages, and we take patients with having grade 1 and 2 facial nerve paresis. Post-operatively, we evaluate the patient after 48 hours and after 7th day. Well, the mechanism of facial monitoring, we use two lead monitoring. One was placed at orbicularis oculi and the other was at oris. The electrical probe was used to stimulate the nerve. These are the nerve patterns when we stimulate the nerve and when the tumor is being resected or distorted. Some protocols we need to follow. We can't use long-acting muscle relaxant, and we need to stimulate the nerve at early point of the surgery before any significant nerve manipulation is performed. These are the nerve leads we performed. The intraoperative view where we have to stimulate the nerve. Well, this is the nerve waveform when the nerve is stimulated. So the pre-assessment of the patient was taken, 10 patients with having 1 and 2 injuries. The post-operatively, we have the efficacy of 70%. Grade 1 having, there was no injury for 4 patients and 3 patients have grade 2. After 7 days, the results were the same. We have 70% efficacy. Good facial nerve functions, grade 1 and 2 was observed in 7 patients among the 10 patients we have operated. Several studies has been investigating the correlation of the intraoperative facial nerve monitoring. And recently in 2005, there was a study in which 75% patient 75% outcome was observed in the patients with 6 months follow-up. To conclude, the intraoperative facial nerve monitoring in modern microneurosurgical technique has led to a dramatic reduction in the morbidity once associated with the CP angle tumor surgery for the facial nerve injury. It improves the quality of patient life and aesthetics of the face after the surgery. These are some references. Thank you very much.
Thank you, Dr. Aman. Now we are going to move on to the next presentation. I would like to call Dr. Mubashir Malik from Punjab Institute of Neurosciences, Lahore. He is going to talk about fluorescent-guided resection in neuro-oncological surgery.
Bismillahirrahmanirrahim. I'm Dr. Mubashir Malik from Punjab Institute of Neurosciences, Lahore, Neurosurgery Unit 2. Today I'm going to present on a topic that is the fluorescent-guided resection in the neuro-oncological surgery. So what are the challenges for the neuro-oncology? As you know, most of the talk over here in this conference is also for the tumors, brain tumors or spinal tumors, etc. So what we face more difficulty, that is during per-operatively, we are unable to identify between the normal and the tumorous tissue in the most of the tumors. For example, most common is the glioblastoma multiforme or the metastasis. As we counsel the patients as well in pre-operatively, as that in our late term language is that ये जड़ों वाली रसोली है. So it is the infiltrating tumor into the normal brain tissue. So we cannot have the some gadgets previously for the differentiation between the normal and the diseased portion of that brain or the tumor. So our study is based on the new fluorescein guidance during the surgery while operating that kind of the tumors. There's a little introduction and the literature review in which it shows that the glioblastoma multiforme is the most common primary brain tumor, and it's very aggressive with the incidence of 12,000 new cases each year. So the treatment of these tumors is the gross total resection, and in such to perform these tumors, we use some adjuvants to the surgery. And these surgical adjuvants are the intraoperative ultrasounds, intraoperative MRI, flare attenuated this MRI sequence, then the neuronavigation, cortical mapping, and the fluorophores. That is the sodium fluorescein and the 5-aminolevulinic acid, known as 5-LA as well. So the GTR improves in the patient survival and the reduce the morbidity and the in newly diagnosed cases of the glioblastoma multiforme. So the current standard of the surgical treatment is the maximal safe resection. The most common used technique while using the intraoperative fluorophores is the fluorescein, and the fluorescein guided resection is also beneficial in the other tumors of the brain and spinal cord. For example, the metastatic CNS tumors and the atypical meningiomas as well. Objective of our study is to establish that the fluorescein guided resection in oncological surgery is beneficial in terms of tumor identification and the gross total resection operatively. These are the material methods in each. This is a cost experimental trial conducted at the Department of Neurosurgery, and its ongoing trial after the ethical committee approval. Inclusion criteria and the exclusion criteria is given here, in which we taken these patients. So this is the procedure, all procedure done by the same surgical team in the Neurosurgery Unit 2, Punjab Institute of Neurosciences. We used the 25% of the fluorescein solution, and dose was the 10 to 15 milligram per kilogram, and we give that dose at the time of bone flap removal, that is the craniotomy. So the extent of the resection of the tumor under the fluorescein guidance will be noted under the paraoperatively and will be confirmed for post-operative MRI or CT scan as well. So these are the results from our study, in which the major group of age distribution and the gender distribution. So the most of the cases were in the age group of 15 to 30 years of the age. This is the wheel representing about the cases, and you can appreciate the major portion of the wheel having the brain's gliomas, which also includes the GBM metastasis and the low-grade gliomas as well. This is the distribution by the type. So the high-grade gliomas were, we are presenting the 13 cases from our series, and 9 were the high-grade gliomas, 2 were the low-grade gliomas, 1 was the spinal tumor, and 1 was the atypical meningioma. And we achieved 84.6% of the gross total resection, that is more than 95% of the tumor we excised while using this fluorescein intraoperatively.
Dr. Mubashir, please be quick, only 1 minute is left.
Yes, not a single case of fluorescein toxicity, that is the renal damage or the anaphylactic reaction, is observed, and this proving the safety of fluorescein in the CNS tumor surgeries. So these are the cases we are presenting from our series. This is pre-operative. This is the intraoperative scan. You can appreciate the tumor bed, which is enhancing after the uptake of the fluorescein. And this is the post-operative scan. This is another case with the high-grade glioma in the occipital region. This is the post-operative scan as well. So at the end, the fluorescein guided section of the glioblastoma multiforme and the metastatic brain tumors proved effective in the gross total resection. In our study, GTR achieved in the 84.6% of the CNS tumors. And this is the references from the other studies which our results were comparable. The point to be noticed that that dose we use, that is 10 to 15 milligram per kilogram, is the dose at which we can achieve more gross resection as well as compared to the other studies. They achieved the 75%, 80%, and the 80%. Respectively. So conclusion is that the fluorescein guided dissection for the complicated tumors like the high-grade gliomas has shown promising results and easily available with a short learning curve for the young neurosurgeons at the centers where the fancy gadgets like the neuronavigation, intraoperative ultrasound, cortical mapping, etc. not available. So improving the patient's care in terms of less morbidity and the mortality. For the resection of the CNS lesions like the spinal gliomas, spinal metastasis, lymphomas, meningiomas, and the cerebral abscess, fluorescein can be a future tool for the maximal safe resection. So these are my references. So any questions will be highly appreciated. Thank you.